Uh, Let us see what chronic dermatophytosis means. And we see a lot of it now, that anything which goes more than 6 months with or without a recurrence, you, in spite of being treated, you would say that it is a chronic dermatophytosis. And if you treat the dermatophytosis and then it settles, but then it comes back within 6 weeks, you would say it is a recurrent dermatophytosis. And sometimes you would see that it comes back after 6 to 8 weeks, then you would probably say it's a relapse. Uh, so recurrence, relapse, chronic, whether it is the same fungus that you treated initially and has come back again because you could not treat the reservoirs. For example, if a patient has got a tinea cruris and a tinea unguium, so if you have treated the cruris part but the nail still remains infected, that can again cause the reinfection of the groin area. So persistence of infection. So these are all the definitions that we use day in and day out for dermatophytosis. Now, this one is a very interesting uh, building, which is termed as an orphanage for children with dermatophytosis. So it is in a place called the Vorovskil Street in Moscow. And 1927, this was primarily the residence of children who had severe dermatophytosis. So definitely we were in that era where the dermatophytosis was a menace. Definitely we overcome that because of not only the pharmacopoeia that we have, but also because of the improvement in hygiene and sanitation and awareness. But now we seem to be coming kind of a full circle again, where dermatophytosis is again becoming a menace. So the objectives are, let us see what the problem is and what are the measures that we can actually take from the dermatophytosis point of view, and giving a bit of a perspective on the pediatric side as well. So the problem is that the prevalence is increasing. Definitely, it was there till pre-COVID times. Then it dropped, and now it is again increasing. And uh, an interesting article was there by Gracer and Scott and Somerville, and they said that probably the concept of categorizing dermatophytes is going to change as we are coming with the molecular diagnosis. But what they also stated was that almost every individual is likely to get dermatophytosis at least once in their lifetime. This was a big statement. And so we can think of what is the number of patients that we have at hand. And it has been said that the global prevalence is about 20 to 25%. That means almost a fifth or fourth of the population has some form of dermatophytes which are sitting on their skin. Uh, this one, I just put it there from Ethiopia from 2015. And if you look at the studies from 2006, 7, 8, and then you compare them with 2015, you will find that the infection is still there, but the clinical patterns have changed. So we used to see a lot of tinea capitis at that point. And if you look at 2007-8 articles, you will find that if there is pediatric dermatophytosis, then the most common, maybe about 50%, 40% would be tinea capitis, followed by some tinea corporis, fasciae, and others. But now the tables have turned, and mostly what you see is the glabrous skin, and tinea capitis is something which we are seeing less and less. Maybe there may be a difference in the rural versus urban population, but still we are seeing less of that. So whether we are going through the cephalocaudal drift, we don't know. Uh, this particular article from 2016, where they looked at the clinical microbiological study of dermatophytosis in a tertiary care hospital in North Karnataka. Again, there is a mention there of a 2007-8 article where tinea capitis used to be the primary clinical pattern seen in children, but then in 2016 it has changed to more of a glabrous skin involvement. So, what is the change in clinical patterns we have seen? So, over a period of time, what we have seen is that the dermatophytosis has become unresponsive. And therefore, what you see nowadays, if you look at the prescriptions from our colleagues, from others, we see many a times a combination of antifungals being used. For example, you mix maybe terbinafine and itraconazole or some other things, which you don't find in the standard textbooks, we don't find in the guidelines. And many a times you just extend the therapy by maybe 2 weeks, 4 weeks, 6 weeks. And we see a lot of chronic infections nowadays where the tinea has been there for a long time despite treatment. Now, the definition goes that despite optimal treatment. So the problem here is that many of the general practitioners and many of the patients who get treated by quacks, they really don't know uh, they are kind of a guideline naive. That means they don't know what the guidelines say. So sometimes you see itraconazole being written for 7 days, and then there's partial improvement. They just stop it, and then again they give it for a few days after 15 days. So this kind of an interrupted therapy many a times actually brings more resistance in the environment as compared to if it was given at a go for whatever period it was needed, 4 to 6 weeks or 8 weeks. Mm. Now we have seen the sea change from Trichophyton rubrum to Trichophyton mentagrophytes, and then now uh, Trichophyton indotinea, which was again previously Trichophyton mentagrophytes type 8, and that has now been individualized as Trichophyton indotinea and indotinea, which is terbinafine resistant. So we have found a lot of terbinafine resistance. In fact, if you look at a few articles from a few years back, you would find that there was hardly any microbiological resistance. All what we were seeing were clinical resistance. That means in vitro, the drugs were working fine. But when it came to giving them to an actual person, the drug was not working. So trichophilon rubrum, probably the rate at which it multiplies is less as compared to mentagrophytes, which has got a higher rate of multiplication. So you see that if one patient gets, you will sometimes get a history that uh, I got that, and within a week, 2 weeks, I see that two of my family members have got the same. So the way it transmits is much faster. Uh, we never used to see adult tinea fasciae long back. It was very rare, and similar was genital tinea. But nowadays you see a lot of adult tinea fasciae, a lot of genital involvement in adults as well. Uh, Tinea incognito or incognita, or uh, what we can say is steroid modified tinea, is something that we are seeing a lot. And I think a major task force of IDVL is working towards that as well, that we should have a ban on the steroid and steroid combinations, which probably are much more used. And I think we'll go through that as the slides progress. Childhood tinea, again, we have seen a lot. So you will see articles of neonates getting tinea at day 2, day 3, day 5. Now, even if you look at the multiplication times or latency period, if you get a transfer, you would not get tinea maybe before 1 to 2 weeks. So how does a child at 2 days or 3 days of age get tinea? So definitely there is we I think the knowledge about the latency periods probably is lacking regarding the newer species or the way the species have changed, and maybe they can multiply faster and produce tinea within a few days. So nowadays, what we are seeing is multiple sites. You're getting larger size lesions. You're seeing eczematous changes in the center of the lesions and pustular borders. If you see pustular borders, if you see eczematous changes, most of the time what we are seeing is actually steroid modified tinea. And same can be said for ring within the ring phenomenon, where it is known as pseudo imbricata. And you're seeing bizarre shapes, multiple annular lesions clustering, and then, as I said, frequency of the male genital involvement has gone up as well. So, kind of change in the clinical patterns, and similar, you would say, that is happening in childhood tinea as well. Uh, this one I just took a snapshot from an article from 1982, so that's long back. So they were looking at the clinical and mycological features of chronic dermatophyte infections, and they found was that the children who had atopy or who had a high IgE levels, those patients actually had higher incidence of trichophyton infections. And majority of them at that point was trichophyton rubrum. Now we have definitely shown a change. So the knowledge that somehow if you have an atopic tendency, the chances of you getting infected by trichophyton or other dermatophytes was higher as compared to the other population, and we know it from the pathogenesis mechanisms now. So this one slide, if you can see on the left side, is a chirion. So that is an inflammatory tinea, and on the right side on the top is the gray patch tinea, and on the bottom is the black dot tinea, which is the ectothrix and the endothrix respectively. So I'm not going too much deeper into the theoretical aspect, because I think that is something which is we have in our books and journals. So Kirion is more of an inflammatory tinea, because mostly it is the non-anthropophilic fungi which when they come, our body generates a lot of inflammation because they are foreign and they are not used to our skin, and that is when we see the Kirion. And I think the question that we all have is whether we should give steroid or not. So sometimes if there's a lot of inflammation, giving a few days of a oral steroid does help in dampening the inflammation and prevent scarring, which might otherwise happen. But definitely a secondary infection has to be seen as well. And sometimes an oral antibiotic for a few days covering definitely staph and sometimes strep might be helpful. And then definitely you need an oral antifungal for 6 to 8 weeks. Sometimes it is given as 4 to 6 weeks, but anywhere between 4 to 8 weeks, something works. And in children above 2 years of age, mostly we prefer giving terbinafine. But before that, fluconazole is something acts. Microsporum canis used to be the most common organism, but nowadays you see more of Trichophyton tonsillensis. So if it is microsporum, but if you have a Woods lamp at hand, you can probably check for fluorescence because microsporum is going to fluoresce, but the other species is not going to fluoresce. And if you get a fluorescence, then probably griseofulvin is a drug of choice because it acts better on microsporum. And if you don't have a fluorescence, maybe terbinafine is something which is going to act. But I use terbinafine much more often and find it very useful in these children. Uh, for the ecto and endothrix, definitely the Trichophyton tonsurans and other groups are more common, and terbinafine acts very well. That is the first line of choice, and we'll see. So what we've seen is that these clinical patterns are not that common nowadays that we used to see before. uh, my practice is much more in kind of a middle to higher socioeconomic group. So definitely we are not seeing, but I do get patients from the rural background. But the number of cases of tinea capitis has gone down drastically in my practice, and maybe you see more on the medical college side. But there has been a shift from this to more involvement of the trunk and the other areas. Uh, so if you look at this child, so this is a 3-year-old child, and what you are seeing here is a big ring. So it is almost covering the entire half the trunk, and even on the front that you can see that you got multiple small, but then you can make out this boundary which is going right across. So 1/3 of the trunk on the front and almost half the trunk on the back, it's a big round, big annular plaque patch. And then what you have got is multiple small ring lesions in the center. So this is a classical ring within a ring in a 3-year-old who has been exposed to topical clobetasol propionate for a rather long time. Now, the problem now what happened is that if I again go back to my residency days in 1990s or so, the mixed creams which were there in the market used to have mostly beclomethasone or maybe fluocinolone. But nowadays it is almost universally it is clobetasol propionate, which is the class one most potent steroid. So the more potent a steroid is, the more immune suppressive it is. So in these areas now, because there is no immunity, you don't see a classical single ring. And so classical single ring was that the fungus moves into the periphery and the immunity actually causes the clearance in the center. Now, because the clobetasol is applied all over, there is no immunity there. So it is all suppressed. And therefore, you see these fungi coming from various places within that ring. So this is almost pathognomonic of having a topical steroid application, which is causing it. Uh, so ring within a ring was described as almost pathognomonic of having a steroid modified tinea. Now this one is an adolescent where you again see a ring within a ring, and there are various bizarre patterns that you can see because of again application of super potent steroids over a long period of time. Now this child, 12 years of age, you can still see the lesions on the buttocks, which are classical tinea. On the abdomen, the lesion is a bit faded off. Again, in the groin, if you see you can't see any lesion there, but you can see a lot of striae. And if you look at the faces, it's a moon faces or a Cushingoid faces. So this 12-year-old had never had any oral or parenteral steroids. What he had was extensive clobetasol being applied across the body for a rather long time. So you have seen striae, you've seen moon-like faces, you're seeing Cushingoid habitus. All happened just because of the absorption of clobetasol over a long period of time, causing HPA axis suppression. So it is not just the young babies who have got a higher body surface area to weight ratio who are going to get an HPA axis suppression, but even children who are slightly higher in the age group also can actually cause that. So when we are applying creams, one should be very, very careful. Definitely, none of the dermatologists are going to actually give clobetasol. It is so rampantly available that that is what. So if you've got a child who's got a Cushingoid facies, not only think of oral and parenteral steroids, also think of application of high potency steroids over a longer period of time. This one again is a steroid modified tinea, but here you can hardly see any central clearance. So this child was being treated. This is an infant and being treated as a spot of eczema for a long period of time. So definitely, when it started, might have started as an annular lesion, but eventually, over a period of time, as the steroid application was there, there is involvement of the center as well. And instead of a ring within the ring, it is almost just like an eczematous appearance, which again is a steroid modified tinea appearance. If you see an annular lesion or maybe just scaling of one of the ears, so it is usually, again, it is tinea or dermatophytosis which is causing it. And because of the application of steroid, you cannot see the margin very clearly, but one can appreciate that there is almost an annularity to the scaling which is there on the ear. And on the abdomen, what one is seeing is again eczematous patches, but this is more of a fungal folliculitis or the Majocchi's granuloma that has set in on this adolescent because of the application of superpotent steroids over a longer period of time. So you can see the bigger lesions are almost annular, but again, then you see a lot of lesions which look like eczema, but they are small annular lesions which are clustered together, and they are plaques, they are elevated, and what has happened is a Majocchi's granuloma which will need a systemic treatment over an extended period to settle this down. So as you see, the patterns have become bizarre. It doesn't appear as a very frank dermatophytosis like you used to see in the textbooks. Tinea facie, again, in children we do used to see on occasions, but adult tinea, no. So this again is an 18-year-old. You don't see, you used to see tinea on face majority of the times, but nowadays it is not uncommon to see annular lesions on the face. Again, genital involvement not very common before, but now you see a lot of involvement of the penile area, the scrotal area, the pubic area, which were not very common before. So the patterns have changed over a period of time. Tinea unguium, very rare in children to see. Uh, Again, this child who is an infant, and you have to rule out a candida there as well. So it might be a candida or a dermatophyte, but nail clippings did show dermatophytosis. In children of this age, the nail plate is very thin, and therefore the topical applications like cyclopyroxolamine or amorolfine usually work very well for a children. But the problem is if they are thumb sucking, then you have to make sure that you have to wrap it up so they don't suck the thumb. Now, the problems, as we discussed, was microbiological resistance versus clinical resistance. And over a period of time, one has seen that both terbinafine and azole resistance is coming into play. So, terbinafine, you see the emergence of terbinafine resistant trichophyton mentacrophytes. And here there was mutation in the scoline epoxidase gene. And then there were literature about the azole resistance as well, which is less as compared to terbinafine. And then suddenly we get one genetic mutation within the mentacrophyte species, where now referred to as trichophyton indoteinae, which has got a scoline epoxidase gene mutation and does not respond to terbinafine. And even though it's the initial case reports were from our side, now you can probably see that the case reports are coming from across the world that trichophyton indoteinae is pretty much becoming epidemic. Mm. So another article from 2018 by Kabir Sardana from Delhi and team. So the question was that is antifungal resistance a cause for treatment failure in dermatophytosis? And what they found was that the MICs, even though they were slightly higher as compared to the Western literature, but they were not high enough to put them in the category of being of causing treatment failure. So microbiological resistance in 2018 was not an issue at all, but still you were getting patients and quite a lot of them who were not responding to the treatment. So there has to be a cause, and ultimately it was thought that it probably was the over-the-counter availability of a lot of mixed creams containing steroids, which probably was the reason. And it was a change in the steroid from beclomethasone to clobetasol that might have contributed as well. And again, another article from 2017 where Dr. Verma And Panda said that there's a menace happening across India. Now, who is responsible? So I think we definitely there has to be a blame game as well as to who is responsible. And if we can find a trigger as to what is responsible, we can definitely hold that there, and maybe that will be helpful. So there are many aspects which is actually causing it, and this is again Th1 Th2 balance. As I showed you one paper from 1982 by Dr. Ray and others, where they found that the children who had got atopy, they are at a higher risk of developing dermatophytosis. So in children, so you see a lot of atopic dermatitis in children. So almost 70-80% actually happens before 5 years of age. So if that is where you see a lot of atopic dermatitis, the chances are that if there is a spread in the society, then these children are at a higher risk. So definitely you are seeing more children with atopic dermatitis, and you are seeing more children with fungal infection or dermatophytosis at the same time. And it is the Th2 skewing of the immunology where you see increased levels of IL-10, IL-4, IL-5 as compared to the Th1, which is protective for the fungal infections. You see more dermatophytosis. Then if you put a lot of steroid on the body, it actually causes a reduction in the phagocytes free radical and nitric oxide generation. So these are the things which they generate inside, and that is what causes phagocytosis of the fungal elements. And if these are suppressed by the topical steroids, then you see more chronic and resistant dermatophytosis. And similar thing happens again with topical steroids, that they tend to down-regulate the TLR4. So these are receptors which, by virtue of them having certain molecules known as the pathogen associated molecular pattern recognition, they can recognize the fungal elements and they can act as the first line of defense. But if they get down regulated, again you get resistant, recurrent, and relapsing dermatophytosis. So these two are just because of the topical steroids or maybe some other form of immune suppression that the patient is undergoing. The fungi have got mannans which are responsible for the initial adhesion of the fungus to the skin, but at the same time, mannans actually downregulate the immunological mechanisms in the keratinocytes. Now you've seen more and more biofilm formation in the fungi as well, where they form fungal colonies and they get wrapped up in a fibrocollagenous mass. And it is difficult for the antifungals or antibiotics to penetrate that fibrocollagenous tissue. And therefore, the fungi sit inside and they are not killed so easily. Now we are becoming more aware of the genetic mutations which puts uh, children at higher incidence of or higher susceptibility to fungal infection, and one of them is card9 mutation. There are more mutations as well. So this is a caspase recruitment domain family 9 mutation, and that puts the patient at a risk of dermatophytosis. As I said, there are host immunity issues. So that might be just a topical immunity issue where you are using a lot of topical steroids, but patients who are on immune suppressive medications, and we nowadays are actually using immune suppression a lot as compared to what you were using before. So if you look at all the newer molecules that are coming, to some extent they are actually playing with the immunity, and they do make us more susceptible or the patients more susceptible to dermatophytosis. So always ask the history if you find chronic resistant dermatophytosis or extensive dermatophytosis. So not only just what they're applying, but what they are taking. Is there any injections of, or they having any chronic conditions? For example, patients with chronic renal failure, patients with leukemia, lymphoma, malignancies, they all are immune suppressed or maybe some primary immune deficiency. Uh, as we have seen fungal drug resistance, so we have got this trichophyton indotinea, which we know is drug resistant to terbinafine. And apart from that, also the drug resistance is increasing. So there are uh, ways in which our antifungal medicines act. So first of all, they have to enter a fungus, then they have to hit their target. So sometimes the entry mechanisms actually they develop resistance, the targets change, or many a times it is the drug efflux mechanism which actually become more efficient, and therefore there is more of fungal drug resistance that is coming up. uh, then if you are especially if you're treating tinea pedis or tinea anguyam on the feet, many a times the terbinafine is not a good choice because it doesn't act against molds. So if you're having these infections on the foot, the azoles are a better choice because they act against non-dermatophyte molds as well, rather than just dermatophytosis. Then we have got compliance issues. So as I said, a lot of if you have a lot of people who are not trained, so quacks, as you can say, the they would not give adequate optimum dosage. They would not give optimum duration of antifungal. So that is one issue from the medical side. And then from the patient's perspective, if you see, if terbinafine is not acting, you don't want to give another one. Itraconazole is expensive. So if it is an expensive medication, and if you've got 5 members of a family affected with tinea, so the cost is a decent cost. Then topical antifungals are really much more costlier than the mixed creams that you can get at a cheaper rate. So compliance issues because the cost is there, and self-medication definitely. So there are betamethasone tubes many a times are just lying on the patient's in almiras and cupboards, and they don't even know it's a steroid, but because it works, they keep on using it. Over-the-counter combination creams is causing a menace because they are much cheaper than the antifungals, and therefore they stay kind of a first line from the chemist side of view, from the patient's perspective. uh, we had a lot of issue with bioavailability of different itraconazole brands. What is the pellet size? What is the pellet number? So maybe we need some kind of a very structured methodology where all brands they act in a similar fashion. In agriculture, a lot of antifungals are used, which are similar to the antifungals we are using. So many a times it is because of the extensive use there, you start seeing cross resistance in humans as well. Uh, in our general practice, the people who are not trained in dermatology or working as general practitioners, we don't still have very clear guidelines for them, and many a time it is the unclear guidelines which is causing an issue rather than they not knowing what to do. Then the environmental changes, people do say that there is a lot of global warming going on, but I think it is the hot and humid areas already used to get a lot of fungal infections, the dermatophytosis. But nowadays, as the weather is expanding across the continent, we are likely to see much more dermatophytosis in the future. Uh, Hygiene is one thing. If you've got overcrowded areas, multiple family members, and hygiene is an issue, the transfer of dermatophytes across the family members is much more. And then sharing of fomites, like sharing of towels, sharing of linen, sharing of combs, uh, sharing of footwear, they all can actually lead to it. We see much more in lower socioeconomic status because I've already mentioned the cost issue, and that is one element. And then nowadays, you see in the upper middle and upper social strata, you see a lot of pets being kept at home. In our rural areas, we already have the cattle which is there. So these again, there can be a cross transfer between the animals, and there are certain dermatophytoses which are zoophilic. So you see Trichophyton verrucosum, you see in the cattle, you can see Microsporum canis in the cats. So you get so if there's a history taking there, definitely do inquire if there is cattle in the family, if there are dogs or cats in the family, and that might be leading to it. Uh, a little things whether we have evidence or not. So itraconazole in unconventional forms, like you see in tablets, it used to come and that was taken off the market, didn't work. And then compounded in beta cyclodextrin, sustained release preparations, we are seeing topical antifungals with penetration enhancers, which again we don't have any articles on. Powder being marketed of itraconazole, again I'm very much against that because again it's going to just increase the resistance if you're using it rampantly as a powder. Topical amphotericin B, I think amphotericin B, we should probably just leave it for its use in deeper mycosis and systemic mycosis as a very useful drug. And if you start using it topically, we might just increase the resistance. And then in varying dosage schedules, you are using for varying durations without performing any dose ranging studies. And therefore, you need studies pan India to come up with one guideline which should be followed across the platform. Uh, so there was again, I'll just refer to one article which said that successful treatment of recurrent dermatophytosis with isotretinoin and itraconazole. And then there was another article which kind of rebutted on that. The question was that because isotretinoin probably increases the cell turnover, it might actually just clear the fungus a little bit quicker. But then somebody realized that isotretinoin reduces the sebum production, and because itraconazole actually is secreted in the sebum, so whether reduction in sebum secretion might actually cause the opposite effect. So maybe you need further studies and larger studies on issues like this before we can put them as guidelines. Uh, so what I would say is that there are various places where you can act to curb this fungus. So the fungus needs a kind of a body temperature on which it multiplies. Then you have the penetration, which has to be there. Then once it penetrates, it has to absorb that tissue. And once it is inside, there has to be resistance to the immune defenses. So we can probably target any of these to prevent this fungus from causing the clinical manifestations. And it involves both non-pharmacological and pharmacological measures. So what should I do? I think the first thing that we need to do is definitely give time to the patient and the family, and they should be able to understand what they're dealing with, how to prevent the spread. So non-pharmacological measures, if you have to give to the family, you have to give time to the counseling when they come for the first time. You suspect, you diagnose. If unresponsive, you take a step back, do a KOH mount, which is the easiest thing to do. uh, it's kind of a family therapy nowadays, as we used to do for scabies. So that it cannot spread beyond, and if it has spread to a few family members, at least it doesn't spread to the other family members. And as I said, both measures are important, and a kind of a rational treatment. So minimum medications, maximum effect kind of a thing. And definitely the pharma industry is innovating over a period of time to see if we can come up with something new. Why should we do so? There are kind of four things that, so we know there are physical concerns, we know there are cosmetic concerns. So as I showed you two pictures of tinea faciae. So if that is a kind of a lesion resting on your face, you're definitely not going to go out, because everybody is going to ask you what is that. So there are cosmetic issues. Physical concerns, definitely it's cause a lot of itching, and therefore you're not comfortable. But at the same time, we should not be ignoring the economic impact. So if you look at this article from 2019, complex cost issues. So the topical antifungal market at that point in 2019 was 1,000 crore. The mixed cream market was a 1,300 crore. That's even a bigger market than topical antifungal. And then if you look at the total antifungal market was more than 2,200 crore. And the authors at that point pointed out that the current number of extremely poor people in India was about 13%. And then the Asia Development Bank estimated that almost 40% of Indian population was middle class. At the max, what they were earning was $10 to $20 a day. So if that is the issue, then uh, maybe we can come up with better brands which can be on the generic side to reduce the costing. But as I said, some kind of a structured thing has to be done so that the itraconazole, we don't have issues of pellet size and pellet numbers and other things, and that will be very, very helpful. So why should I do psychological impact? There are many case reports, and this is just one by Dr. Tarun Narang and others from PGI. And they looked at the quality of life and psychological morbidity in patients. And they did a dermatology life quality index, or DLQI, and a general health questionnaire, or GHQ, respectively. And what they found was that almost 90%, almost 85% of the patients, they had a high score, indicating significant psychological distress. So psychological distress is not just physical. So now it is a combination of physical, cosmetic, economic, and then the stress. So it is a combination of so many things that is causing the psychological distress and has to be taken care of. So before you treat, just be sure what you are treating. So as I said, if there is a doubt, for example, in steroid modified tinea, many times it is difficult to actually ascertain that this is tinea. Even without that, sometimes you get tinea corporis and you are just scratching your heads whether it is any other annular lesion that you are thinking of. It's annular psoriasis, something else. So sample collection is important. How to collect the sample? So from the periphery of a plaque, you can use a scalpel or an edge of a slide or a curette, and send it in a black paper to the lab for KOH mount. Direct microscopic examination is best. In fact, what you are seeing on the background is a pink background with these blue hyphae. This is a Chicago sky blue stain with 10% KOH. So what that does is, because in KOH you don't get that color contrast. So in this one you get a color contrast where the fungal hyphae become blue, and it is much more easier. The best you can use is probably a fluorescent microscope, but it is not easily available at most places. Wood's lamp definitely are very much help, especially Tinea capitis microsporum species. Dermoscopy has come a long way, and I think you've got huge books on dermoscopy. And again, there are specific markers for fungal infection, especially Tinea capitis. You see comma hair, you see fragmented or fractured hair, you see corkscrew hair, Morse code hair. So there are multiple markers in dermoscopy you can use. Fungal culture, again, it's a kind of a gold standard, but again, the specificity is great, but the sensitivity is not very high. But that can be done. Histopathology is again can be resorted to if you're unsure of the diagnosis. And then newer methodologies like PCR, MALDI-TOF MS, which is a matrix-assisted laser desorption ionization spectrometry. It has come a long way, but it's expensive and it's not easily available. Reflectance confocal microscopy is very useful. Again, mostly not available. So when you treat these children, what is the determinant of treatment? So definitely the type of fungal pathogen. So for example, if you have got an endothenia there, then you probably are going to go towards the azole side. But how to know is the big question. The site and severity of the infection, then the age, the immune status, and comorbidity. So that comes to the history taking part, that you can determine what kind of a treatment you want to give. Non-pharmacological actually go very, very quickly. So loose cotton clothes. So the more you sweat, the more problematic it is. So the loose cotton clothes, the less sweating is there, the less friction is there. Don't share towels, linen, and clothes because they are fomites. It can cause transfer of dermatophytosis. Fomite disinfection, again, there was use of bleach and sodium hypochlorite if possible. So you can disinfect the articles. The clothes, a hot water wash and ironing actually causes a lot of damage to the fungi as well. So that can be done. And if the family members who are infected, the clothes should be washed separately from the rest of the family members. For the children who have got a higher BMI, reduction of weight definitely helps because in the folds in obesity, there's a lot of sweating there and maceration there that that damages the barrier of the skin and therefore causes much more easily the fungi to enter the stratum corneum. Twice a day bath with change of clothes and thorough drying. Sorry. Family contact tracing and treatment like we used to do for scabies, again, it is very important nowadays for dermatophytosis. Avoid occlusive footwear. Powders on the feet can help in absorption of the sweat to some extent. In public washrooms, just use slippers, and same as in the public swimming pools. It's not difficult to actually catch dermatophytosis from there. Trim the nails, don't share nail clippers. So if you've got a tinea unguium, and many times if you've got tinea corporis, if you're scratching, the fungi can deposit just beneath the distal edge of the nail, and therefore just keep the nails trimmed. uh, Caution regarding manicures and pedicures from where you can get the fungal infections. Shoe disinfection, there's only one article I could see, and examine the pets because it can be a zoophilic fungi coming from your pets. Now, uncomplicated infection on the non-hairy areas, the topicals usually work very well. So, children, what is there is that there's the turnover rate of the epidermis is higher as compared to adults. So, the things actually get ridden off much more quicker than an adult. So, many a times, even with a few patches, you can get away with just by using topicals. And I think we are all are using a lot of imidazoles and triazoles. Triazoles are largely oral. Imidazole you're using topical. So we used to use a lot of clotrimazole, but nowadays, recently, I think laliconazole is something which is working quite nicely. So laliconazole, bifonazole are something you can use once a day. The rest are usually twice a day applications. And there's kind of a rule of two for applying topical antifungals that when you're applying it, use it usually twice a day, use it up to 2 centimeter beyond the lesion, and you use it for at least 2 weeks beyond clinical resolution. So that's kind of a rule of two for applying the topical antifungals. Again, means, as I said, terbinafine resistance has been there a lot, but nowadays I think we are again getting back to, unless you're getting the variants which are resistant, the resistance to terbinafine for the rest of the fungi is actually decreasing and seeing more responses. In children, as a rule of thumb, I usually use terbinafine as a first line as compared to the azoles. Cyclopyroxylamine is another one which can be used. The resistance is less, and it has also got some anti-inflammatory and antibacterial activity as well. So if you've got a tinea pedis, many a times using cyclopyroxylamine is a better alternative. Morpholine derivatives like amorolfine actually is working very well. Nystatin doesn't work against dermatophytes. It's a pure anti-candida, so we should not be using nystatin. Uh, Now, when do you want to use a systemic treatment in children? So there are areas where the topical agents are not going to penetrate. So if you've got, for example, tinea capitis, so if you've got an infection which has entered the hair, the topical treatment does not enter here. So you have to use a systemic that can actually go there. But at the same time, in tinea capitis, we tend to give antifungal shampoos for a while. So that just reduces the spore load on the scalp, and therefore the chances of spreading across is less if you're using an antifungal shampoo. But definitely, when you use, just let the child have the shampoo on the scalp for at least 5 minutes before you wash it off. And many a times we give it to the family members so that if somebody has got spores sitting onto the scalp, they can be taken care of. If you've got a widespread infection, definitely you cannot use a topical or a larger surface area. So you go for a systemic. Sometimes you have given a topical, it's just not effective. So if it is not effective at all, do think about the diagnosis as well. Take a step back, just make sure you are dealing with tinea. And if it's not being effective, you need a systemic treatment. And then definitely steroid modified tinea, because the surface where the steroid is used, actually the immunity is suppressed topically, and many a times just using a topical doesn't work. And sometimes, as I've shown before, with the steroid modification, you see fungal folliculitis or Majorque's granuloma, and again because it has got deeper into the hair follicle or into the deeper areas where the topical doesn't work. So if you're looking at the pharmacological measures in children, uh, we can use terbinafine, itraconazole, fluconazole, all three, because they're available for children in special preparations. For example, terbinafine, you do find 125 milligram dispersible tablet in the market. Itraconazole, now we have got a solution 10 milligram per ml. Fluconazole, you've got a 1500 milligram dispersible tablet that can be used. So in children, if you look at the box on the top, it says azoles once or twice daily and terbinafine twice daily. But now so this one is something from 2017. It used to say 2 to 4 weeks, but maybe we have gone beyond that. I usually give it for at least 6 weeks and maybe 8 weeks, the topicals, and the rule of two we have gone through. Uh, the first choice in children usually stands as terbinafine. So terbinafine is fungicidal. So the squalene, which actually accumulates because it inhibits squalene epoxidase, is completely toxic to the fungi, and fungi die. The azoles, on the other hand, are mostly fungistatic. Even though on higher doses they can be fungicidal, but mostly fungistatic. So preference is terbinafine, except that the resistance pattern is increasing, and it is weight-based dosage that we are using. Itraconazole you can give 5 mg per kg per day, and there are articles where the solution is more bioavailable. So if you're using a solution, maybe 3 mg per kg per day will suffice, and you can give for a duration depending upon where the infection is. And griseofulvin can be given beyond 1 month of age, and it is available again as a suspension you can use now. And it comes as ultra micronized or micronized. So if it is micronized, you give around 10 mg per kg per day, and ultra micronized, you give around 20 mg per kg per day. But for tinea capitis, you will have to go to almost like 8 weeks or beyond to treat, and therefore sometimes terbinafine actually works much better because the it can be given just for 4 to 6 weeks, and it can be, but below 2 years of age, mostly I prefer fluconazole that can be given on a weekly basis, uh, or sometimes you do give 5 to 6 mg per kg per day for a few weeks. It depends upon how bad the infection is, but usually the weekly dose actually works very well. What is not nowadays eligible is that textbook protocols are probably out of the window. So if you look at the textbooks, they probably will still stay 1 week to 2 weeks, and in the scenario that we are now, those don't work. Topical steroids are a complete no. So I think from day one, you have to make sure that the patient stops the topical steroid. So if they keep on using topical steroids, then they are very, very difficult to treat. And the more time you are on topical steroid, the more difficult it becomes to get off it. There can be kind of a rebound inflammation when you take the steroid off. So some people do prefer maybe giving a lower potency for a short period of time. But I think if you just discuss and counsel that the inflammation is going to be there only for a few days and settles down nicely, then mostly definitely give antihistamine to curb the itching which is going to be there. Uh, what the problem with steroid is that, or the good thing about steroid as far as the patient is concerned, is that steroid just reduces the redness and the itching, and therefore the patient thinks that the patient the things are getting treated. But when the steroid is removed, it all comes back with a vengeance. So you have to tell that it is just these two things that the steroid are taking care of. The actual fungus or the problem is actually increasing because of the steroid. And if you're able to counsel them this, they are more than happy to just get that a little bit of inflammation for a few days. uh, Now, combination oral antifungals, usually I don't prefer. So now the guidelines actually say about the combination. I do extend the therapy by a few weeks if it is needed, rather than combining. High dosages, again, I usually prefer not to. And again, extended dose schedule is much more prevalent as far as I'm concerned. Antifungal powders, uh, they don't have much of an antifungal property as such, because you don't see, uh, they don't penetrate the skin. So whether they are useful or not is a big question. They may just be helpful for maybe absorbing the sweat, but then even a simple talcum would do. As I said, amphotericin gel preferably not to use, because just leave it for the deeper mycosis and the systemic mycosis. Again, oral voriconazole, I've never had a chance to use for dermatophytosis. Uh, I think many a times it is more of the counseling and changing the lifestyle and taking those measures that are helpful, rather than actually increasing onto the higher antifungals, which is better left to for patients who are having systemic mycosis. Uh, these are pharmacological measures from the adult side. Again, not much change, except that again it is from 2017, and you will see majority of them being given as 1 to 2 weeks, 2 to 3 weeks, 3 for 4 weeks. So we probably have come beyond that, and minimum kind of a 4 weeks or maybe 4 to 8 weeks, something that we give to get settle the things down. Uh, So that was in 2018, just an year after those guidelines came, and just in a year you can see a change. That now tinea pedis, recalcitrant or severe cases, you give more than 4 weeks. Tinea corporis and cruris, again naive cases 2 to 4 weeks, but in severe cases 4 weeks, more than 4 weeks. Now more than 4 weeks doesn't have an end. So maybe 4 to 6 weeks, or maybe 8 weeks, or even beyond, depending upon how the clinical response is. Tinea incognito, you will need 4 to 6 weeks or more. So this is from the adult side, but you can probably just extrapolate to the children's side. Rather than saying itraconazole 100, 200 mg per day, we can say 3 to 5 mg per kg per day. And it says continuation of systemic therapy after 2 weeks of clinical resolution. So once the clinical resolved, we used to say that as a rule of two for topicals, but even for systemic, it is better to use it beyond clinical resolution. Sometimes using keratolytics like salicylic acid on the feet, where you have got some hyperkeratotic response, or use of moisturizers because the skin barrier gets affected, is preferred as an adjuvant therapy. Just a few more slides. So we compare the skin kinetics. So uh, if you look at, mm, so these are the areas where the uh, different antifungals are secreted. So in the sweat, you see a lot of fluconazole and griseofulvin coming. So uh, there are people where there was it was uh, kind of proposed that if you give fluconazole or griseofulvin, maybe after a few hours, if you exercise in sweat, you might have higher uh, quantities of these into the stratum corneum. But I think it's just to make sure that the people who have got high sweating rates, sometimes fluconazole and griseofulvin might work better. If you've got terbinafine and itraconazole, they are secreted through sebum, and that is where the controversy regarding isotretinoin came. That if you give along with, and the sebum secretion is reduced, then maybe the amount or the levels of itraconazole in the sebum might actually decrease. So these two actually go through sebum. Uh, Keratin adherence, if you see, it's very strong for terbinafine and itraconazole, and it is the keratin adherence which probably led us the to the type of therapy called pulse therapy, because itraconazole, once it is there in, if you give in higher dosages for 7 days, it stays into the stratum corneum for a very long time because of keratin adherence. And similarly, terbinafine pulse therapy has also been advised, and you can find articles where double the dose is used for 7 days, and then again you give a gap of 3 weeks. So it is just because there is a keratin adherence. So I think innovation, what I would say is that there's a need of the day that we bring in newer molecules, or maybe we just innovate around the previous molecules. I would just go through very, very quickly. So we have got essential oils which are being studied for as antifungals. We have agents like linalool, which has been shown as an antifungal activity. 10% zinc sulfate solution has been tried. Terbinafine loaded wound dressings have been tried. Photodynamic treatment has been tried. Lasers and photodynamic therapy for onychomycosis, something which has been found to be effective. And then we have got newer antimycotic agents are being used again and again. Even older ones like Whitfield's ointment and Castellani's paint are seeing a resurgence to be used in fungal infections. So I think in the end, what I would say is that fungi are not. I think we probably are more bad than the fungus than the fungus is. If you look at all the plants in your garden, all the crops, and think they all depend on fungal associates to grow. Uh, we get medicines, for example, cyclosporins come out of a fungus. If you look at all the farm animals, their gut have got fungi which are needed to digest the grass. And then fungi are the one which degrade the wood. So if they don't degrade the wood will just lying there as a dead timber. So we thank fungus for many things, but the problem is that once it actually invades us, the problem exists. We need periodic epidemiological studies. We need Indian data. So we cannot rely on the outside data. The more Indian data we have, the way the fungus reacts in our bodies may be different than what it reacts in the other ethnic populations. We need our guidelines to be updated periodically, and both non-pharmacological and pharmacological measures are equally important. We should stop mixed creams, and that is something which the IIDB has been working very hard to propose. We should save our existent molecules, and I think save molecules like voriconazole, save molecules like amphotericin for systemic mycosis and not to be used topically or orally. For these amphotericin, we don't have oral; we have just IV preparations, and those don't use them as powder, don't use them as creams. So probably we are the bigger culprits than the fungus, but again, we have to make sure that we better ourselves. So 2019, the theme of IIDVL was fight the topical steroid misuse, and it still remains kind of a very important theme because we still see a lot of prescriptions with that. So maybe let us hope that in the future this happens and we just see a stoppage of mixed creams being used right, left, and center. Thank you very much.
Thank you, sir. Thank you for that excellent lecture. Sir, if you could just stop sharing the screen. Yeah. Um, we'll just have
Right.
a quick quiz, sir. After that, we will take up questions.
Yeah.
Mr. Rupam, can you share the slides? Right. We
Yes.
can go to the next one. Yeah. Yeah. Next slide. Yeah. So these are the winners of session number 174. So Dr. Grishal Quadras from Mangalore, Dr. Chandan Kumar Sahu, SCB Medical College and Hospital, Cuttack, third year postgraduate, and Dr. Archie Ranka from Gandhinagar. So congratulations to all of you, and we will be receiving your participation certificate for the quiz by email from the Achanta team. So let us now move on to today's quiz. So this quiz is only for postgraduates. So kindly type in the answer in the audience comment box as one single answer. The first three entries with correct answer will receive a certificate of appreciation. And there are no negative marks for this. Okay, let's begin. So see that all of you have typed the question at the same time. Yeah. So this is the first question. Tinea recidivans refers to. So kindly don't type in the answer now itself. Let all the five questions come and then type in your answer. Question number two. Which of the following is the most important factor responsible for double H tinea? A. Use of oral antifungals in inadequate dosage. B. Erratic application of steroid containing fixed dose combination. C. Secondary bacterial infections. D. Excessive sweating and occlusion. Question number three. Repeated cycles of inflammation being switched on and switched off over a long period of tinea can result in A. Chirion formation. B. Tinea pseudoimbricata. C. Mejoki's granuloma. And D. Dermatophytid reaction. Question 4. Which of the following best describes the immune dysregulation in chronic dermatophytosis? Option A. Exclusive suppression of Th17 without Treg involvement. B. Reduced CD4 T cell markers in all patients. C. Higher expression of Th17 and T regulatory markers with altered Th17 T regulatory balance. And D. Complete absence of inflammatory cytokine response. And the last question. Which of the following definition is incorrectly matched? That's how Sir began his lecture by giving us all the definitions of chronic dermatophytosis, recurrent dermatophytosis, relapse, and reinfection. We'll just wait for a couple of seconds. So see that all of you have written your name, okay, your contact number, and option question number one, A, B, C, D, like that. Question two, and you can just mention the correct options only. See that it is in one message. I think we can see some answers, but see that you've answered together. You can see four answers, but do not give answers separately. Give it as a single message. We'll wait for another 30 seconds. Another 20 seconds to go. Type in the answers in a single message. Right. Right. I think, okay, fine. We can go to the answers now. Right. So these are the answers. So this was question number one. Tinea recidivans is appearance of dermatophytosis is differentiate after apparent cure. Double H tinea was erratic application of steroid containing fixed combinations. Repeated cycles of inflammation being switched on and off over a long period of time results in tinea pseudoimbricata. Higher expression of Th17 and T regulatory markers with altered Th17 T regulatory balance best describes the immune dysregulation in chronic dermatophytosis. Relapse is the presence of lesions appearing more than 6 to 8 weeks after clinical